Hey there. Today I have an interesting topic to cover with you. Inpatient coding is easy if you understand the clinical and the coding guidelines for any condition. Today we are going to explore more about the most important topic, infectious and parasitic diseases. First, let's learn how to code for infectious and parasitic conditions. Let's get into the details without any delay. We are going to explain to you the terms, definitions, official coding guidelines, and the coding clinic updates. Obviously, it's boring and lengthy to listen to all at once, so we shall break this down into shorter informative sessions so that we all can understand the concepts. To begin with, terms to know. What is bacteremia? Bacteremia is nothing but the presence of bacteria in the bloodstream after trauma or an infection. What is sepsis? Sepsis is defined as systemic inflammatory response syndrome, or SIRS, due to infection. A severe case indicates organ dysfunction. What is SIRS? Systemic inflammatory response syndrome, a systemic response to infection or trauma with such symptoms as fever and tachycardia. Septicemia, a systemic disease associated with pathological microorganisms or toxins in the bloodstream. Septic shock, circulatory failure associated with severe sepsis. Use of alphabetical index. A single code is assigned to indicate the organism. For example, code B26 is assigned for mumps. Some codes of this type use a fourth character to indicate a site or an associated condition. For example, code B37.1 is assigned for candidiasis of the lung. Combination codes frequently identify both the condition and the organism. For example, J15.212, pneumonia due to methicillin-resistant Staphylococcus aureus. B26.0, orchitis due to mumps. Dual classification is also used extensively. For example, B49 plus J99, bronchomycosis. B39.9 plus H32, chorioretinitis and histoplasmosis. Once the main term for the condition has been located, a subterm for the organism always takes precedence over a more general subterm, such as acute or chronic, when both subterms occur at the same indentation level in the alphabetic index. For example, for a diagnosis of chronic cystitis due to gonococcus, the alphabetic index provides subterms for both chronic and gonococcal cystitis exudative. Chronic N30.20, gonococcal A54.01. When the organism is specified but is not indexed under the main term for the condition, refer to the main term infection or to the main term for the organism. Sepsis, severe sepsis, and septic shock. Bacteria is the most common cause of sepsis, but it can also be due to fungus or a virus. When this occurs, the patient's blood culture will oftentimes be positive for the causative organism. However, a negative blood culture does not negate the diagnosis of sepsis. When the blood culture is negative, the physician uses other clinical findings of the patient to make the diagnosis of sepsis. The most common clinical findings that are used by physicians to make this diagnosis are high fever or low temperature, usually greater than 100.4 degrees Fahrenheit or hypothermia, less than 96.8 degrees Fahrenheit tachycardia, usually heart rate over 90, confirmed or suspected localized infection, decreased mental status, tachypnea, usually respiratory rate over 20, chills due to fall in body temperature, hypotension, and elevated white count, more than what is seen with just a localized infection, usually less than 4,000 or greater than 12,000. Severe sepsis occurs when sepsis progresses and signs of organ dysfunction or failure occur. Septic shock is severe cardiovascular dysfunction with extremely low blood pressure and hypoperfusion that does not respond to intravenous fluids. A physician query is required to clarify whether organ dysfunction is related to sepsis if not documented clearly. Cryptic septic shock is another type of shock being documented. These patients have severe lactic acidosis, 4.0 millimoles per liter or greater, and clinical signs of shock. The blood pressure may be normal in patients with cryptic septic shock. All patients should have a serum lactate measured that present with signs of sepsis. This elevated value may alert the physician of cryptic shock. Lactate measured that present with signs of sepsis. This elevated value may alert the physician of cryptic shock. When do we code for severe sepsis and septic shock? For coders, if the physician has documented severe sepsis, linked an acute organ dysfunction or failure to sepsis, or the ICD-10-CM index to diseases directs the coder to the code for severe sepsis, it may be coded. There are two codes for severe sepsis in ICD-10-CM that are reported in addition to the code for sepsis and any organ dysfunction or failure codes. R65.20, severe sepsis without septic shock, and R65.21, severe sepsis with septic shock. Neither of these two codes are acceptable as the principal diagnosis. The ICD-10-CM index does have instructional notes to code first the underlying infection. There are also instructional notes to use additional code to identify specific organ dysfunction. There are several organ dysfunctions listed in the ICD-10-CM index, but this list is not exhaustive. A query may be necessary to clarify if the documentation is describing organ dysfunction or if the organ dysfunction is related to the diagnosis of sepsis. The WITH guideline in the official coding guidelines, section 1A15, does not apply to sepsis and organ dysfunction. The link must be made by the physician. When multiple conditions are responsible for the diagnosis of sepsis and the alphabetic index, tabular list, or other chapter-specific guideline are not present, either of the conditions may be sequenced first. Let's code a case. What's up, suicide? An 85-year-old patient presents with altered mental status from the nursing home. She is noted in the emergency department to have fever, tachycardia, hypotension, elevated lactic acid, and oxygen saturation of 76% on room air. The patient was intubated and placed on mechanical ventilation. Labs were drawn, and the patient had a chest X-ray that showed pneumonia in both lungs. She was admitted with the diagnosis of pneumonia with acute respiratory failure and sepsis. She was worked up and found to also have an indwelling Foley catheter that appeared to have been in place for a long time. This was removed and cultured. The labs came back to show that the patient had E. coli on the catheter tip, as well as E. coli in the urine specimen that had been sent to the lab. Intravenous antibiotics were adjusted to cover the urinary tract infection. The patient required vasopressors for hypotension that didn't respond to intravenous fluids. Despite the intravenous antibiotics, fluids, and intravenous vasopressors, the patient expired. The final diagnoses were 1. Bilateral pneumonia, most likely due to aspiration pneumonia. 2. E. coli urinary tract infection due to indwelling Foley. 3. Acute respiratory failure due to pneumonia. 4. E. coli sepsis due to both aspiration pneumonia and urinary tract infection with septic shock. There were actually two possible selections for the principal diagnosis. Sepsis is documented to be due to both aspiration pneumonia and urinary tract infection, secondary to indwelling Foley catheter. Treatment seems to be equal with intravenous antibiotics, fluids, and vasopressors. In this case, we went with A41.51, sepsis due to E. coli, as the principal diagnosis since it was one of the possible choices, and it is the most resource-intense diagnosis-related group. Rarely will there be more than one diagnosis that meets the definition of principal diagnosis, but when there is, without further sequencing direction, either may be sequenced first. Is this knowledge sufficient for mastering sepsis? The obvious answer is no. There is much more to it. Until then, I will let you sit on the sofa and relax. Yes, we are going to learn something about SOFA in our next session, which helps us to understand the concept of querying in the world of sepsis coding. Hit the like button if you like this video and stay connected for more and more updates.